This is Schistosomiasis by Vanessa Linares and Natalie Phillips.
We are going to start with a brief introduction to schistosomiasis. What exactly is it? Schistosomiasis is a parasitic disease caused by a flatworm from the genus Schistoma. It is predominantly found in tropical and subtropical regions where it affects over 200 million individuals worldwide. The disease is particularly prevalent in sub-Saharan Africa, but also can be noted in South America, the Caribbean, the Middle East, and Asia. The transmission of schistosomiasis occurs through contact with bodies of fresh water, like lakes and rivers, that have been contaminated with larvae from infected snails. These larvae are released by infected freshwater snails, which serve as the intermediate host to the parasite's life cycle. Humans become infected when the larvae penetrate the skin, which occurs primarily through hair follicles, but can happen through small cuts as well. The disease has a complex life cycle and does require both the snail host and a mammal host. Schistosomiasis is considered one of the most widespread parasitic infections with significant impacts on health and quality of life. Schistosomiasis, once known as bilharzia, has a long history spanning from ancient civilizations to modern times. It wasn't officially discovered until 1851 by German physician Theodor Bilharz, who's pictured to the left. He was conducting an autopsy at a hospital in Cairo when he discovered the unusual parasitic worms in one of his patients. There is, however, evidence suggesting these symptoms can resemble those of modern-day schistosomiasis, dating back to that time in ancient Egypt. In 1858, David Frederick Wineland proposed the name to be changed to schistosomiasis. This suggestion was made at the basis of the morphology of the male worm. Schistosomiasis can be broken down from the Greek words into schisto, meaning split, and soma, meaning body. This is a reference to the worm's body shape. The formal name, schistosomiasis, was accepted and now used by the International Commissions on Zoological Nomenclature. As mentioned earlier, the life cycle includes definitive host and an intermediate host. Acknowledgement of this intermediate host did not surface until 1902. Scottish physician Robert Thomson Leiper was the first to understand the complete life cycle of this parasite, and this didn't emerge until 64 years after the initial discovery. Current research using advanced diagnostic testing methods, including polymerase chain reaction, or PCR, are currently being utilized to prove traces of schistosomiasis exist in mummified remains.
Over the past 5 decades, the distribution of schistosomiasis has undergone many changes, and even though there have been effective control programs implemented, the number of individuals infected or at risk remains unchanged. Schistosomiasis is still prevalent in 75 countries and territories, which about 90% of the people reside on the African continent. Schistosomiasis is poorly recognized in early stages because initial symptoms could either be mild or absent. By the time symptoms become apparent, the disease may have already caused damage to internal organs. This could be fatal for people who do not have access to proper health care. In 1984, the WHO Expert Committee on the Control of Schistosomiasis introduced a strategy to decrease the number of casualties. Prices for necessary drugs were high, so active diagnoses and treatment were the most cost-effective, and thus the preferred strategy. This strategy involved the widespread distribution of praziquantel, the main drug used to treat schistosomiasis. According to Armiger K. Deal, this therapy was distributed primarily to school-aged children, 5 to 15 years of age, who have the highest infection burden and who can be reached efficiently through schools.
In 1991 and 1993, the WHO Expert Committee on the Control of Schistosomiasis again tried to focus and update the strategies for the control and management of the disease. They emphasized the importance of an integrated control approach, which combined chemotherapy with drugs like praziquantel as a preventative. They also emphasized the importance of snail control measures, health education, improvement in sanitation, and access to clean water. Additionally, attention was drawn to the necessity of surveilling and monitoring the prevalence and transmission of schistosomiasis to enhance the effectiveness of control measures. This meant providing guidance on the implementation of mass drug administration programs. According to Joseph Mwenga, who conducted a qualitative study on villages who did not show a decrease of schistosomiasis even after the implementation of MDA programs, shares, in both persistent hotspot and responding villages, schistosomiasis was not considered to be a priority health problem because of its chronic nature, lack of knowledge and awareness, and poverty among study communities. Among these villages who showed little to no improvement were negligent leaderships that failed to properly provide care and education for the community. In efforts to improve intervention and strategies, an evaluation on community knowledge, attitudes, and practices on schistosomiasis was done on high prevalence districts in Kenya. As shared by Rosemary M. Musuva, the majority of participants reported having heard about schistosomiasis through schools, posters, radio announcements, and community gatherings. Even though schistosomiasis was nothing new to the people of the community, there were still many misconceptions about the parasite. Some misconceptions about contracting schistosomiasis included drinking dirty water or consuming uncooked or contaminated food. Another misconception was that the diagnosis and treatment were expensive. It is believed these misconceptions and inaccurate information about the transmission of schistosomiasis might arise from the lack of interest or effort to understand the disease.